Okay, I see good number of participants, so maybe we may start with introduction. So once again, hello everyone, hello dear colleagues. Thank you for joining us and welcome to the series of educational webinars from the SIOP GHN Psychosocial Wellbeing Working Group. I'm Alisa Kamalyan from Armenia, co-chairing this group from my colleague Ayushi Kaneja from India. As you may know, June is Cancer Survivorship Month, and our group initiated a webinar in collaboration with the SIOP Survivorship Network. And I'm eager to introduce our colleague from the Survivorship Network, who will co-host today's webinar, Maria Olsson from Sweden. Hello, Maria.
Everyone. Hello, everyone. We are happy to share this webinar together. So I think it's a great opportunity. My name is Maria, and I'm a pediatric oncology nurse working in long-term follow-up clinic in Sweden. I'm part of this newly started, actually, survivorship network group. I have pictures of who we are and a little bit about us, but we can do it afterwards at the end of the presentation, I think. Thank you.
Okay, so a couple of words about Psychosocial Wellbeing Group. Psychosocial Wellbeing Group strives to be a platform for connection for psychosocial professionals working to improve the quality of life for children and their families by promoting a multidisciplinary approach to the psychological aspects. And one of our ways to aim, this goal is through educational webinars with specialists from different backgrounds. So I'm excited to present our today's speaker, Dr. Anna Jones, who is assistant member in the Department of Psychology and Biobehavioral Sciences at St. Jude Children's Research Hospital. Prior to joining the faculty at St. Jude, she completed her PhD in clinical psychology at the University of Georgia. And currently, Anna serves as the psychology lead for the institutional transitional oncology program at St. Jude Hospital. And Anna today will present for us the topic about the importance of psychosocial screening and support in early survivorship. Now, Anna, the floor is yours.
Wonderful. Thank you.
And can I just interrupt? I'm sorry, Anna. I just think if you want to ask questions during your time, you can write in the chat and we can read them at the end. I just want to say that. I'm sorry.
Yes, no, thank
you.
Absolutely.
Wonderful. Well, I'm really excited to talk to you all today about early survivorship and why it's such a pivotal time for screening and intervention on the cancer care continuum. Before getting started, I'd like to thank Alisa, Ayushi, and Maria for inviting me and hosting this talk today. Before I jump in, I have no disclosures. Okay, so I'd like to start by talking about transition and what this means. So transition's traditionally thought of in pediatrics as the movement from pediatric to adult healthcare. And while this is certainly a big transition point for our adolescents and young adults, there's a lot of other meaningful transition points that get overlooked. Wilkins and colleagues provide an alternative definition for transition and describe transition as complex processes indicative of passage or movement from one space or time that involves some degree of self-redefinition, which I think is a really nice broad way to think about transition. This model, also introduced by Wilkins and colleagues, walks us through many important transition points within the cancer care continuum, including diagnosis, treatment, and long-term follow-up. It also differentiates between diagnosis as a child and diagnosis as an adolescent or young adult and subsequent cancer care. And one thing I really appreciate about this model is that it recognizes that this path is not always linear. So now I want to step back from a more complex model and simplify things a little bit by highlighting some of the major milestones within the cancer care continuum. So while we'll highlight diagnosis and treatment, much of today's talk will be spent addressing survivorship. So while this model is certainly not comprehensive or exhaustive, I'm really hopeful that it'll provide a clear framework throughout this talk. So diagnosis is typically seen as the first major transition point within the cancer care continuum, followed by the initiation of treatment, which might include chemotherapy, radiation, surgery, or immunotherapy. Following completion of treatment, patients are typically categorized as off therapy and enter into this early survivorship period where they're undergoing routine surveillance for cancer recurrence, as well as late effects. Once patients transition from early survivorship into long-term survivorship, they undergo periodic late effect surveillance in accordance with guideline recommendations. Oh, and here we are. Here are our 3 time points. Okay, this model by Nathan and colleagues addresses many of the important transition points for pediatric oncology patients and really nicely weaves both medical and psychosocial aspects of transition while giving providers points to consider at each transition juncture. For example, they talk about discussion of future fertility at diagnosis, potential impact of treatment on the ability for individuals to have children of their own via natural birth and traditional conception. Review of treatment exposures and risks at the end of treatment, provision of treatment summary and survivorship care plan at entrance into long-term survivorship, and support for obtaining appropriate health insurance coverage at transition to adult care. So as I mentioned, the first major transition occurs at diagnosis in the beginning of treatment. And this is often a frequent touch point for psychosocial support, allowing for a pathway for intervention for psychosocial needs during treatment. So a lot of times this serves as the time point where individuals are assessed for whether what level of psychosocial support that they will require during treatment. And at St. Jude, psychology sees all patients and families at this time for a consult to assess psychosocial factors which may impact adjustment to diagnosis and coping with required treatment through our new oncology program in psychology, which is led by Dr. Elise Heidelberg. Historically, the next systematic psychosocial touchpoint for many patients and families has been upon entering long-term survivorship. However, the time between treatment completion and eligibility for long-term survivorship care typically spans 2.5 to 5 years, which leaves a massive window of time during the critical transition period between treatment completion and entrance into long-term survivorship, in which families have not historically benefited from systematic psychosocial support. So as I'm sure all of us on this call are intimately familiar, the standards for the psychosocial care of children with cancer and their families was published within Pediatric Blood and Cancer in 2015 and really spearheaded by Lori Weiner. And these standards provide systematic, evidence-based standards for psychosocial care in pediatric oncology. And I'd like to point out 3 of the standards that I think are particularly relevant during early survivorship. So first, standard number 1, which states that youth with cancer and their families should routinely receive systematic assessments of their psychosocial healthcare needs. So really highlighting the need for these assessments to not just happen once, but to happen throughout the cancer care continuum, which would include early survivorship. Standard 3 is typically geared more at long-term survivorship. However, I think that there are a lot of really important points that are applicable within early survivorship too. The standard states that long-term survivors of child and adolescent cancers should receive yearly psychosocial screening, and that AYA survivors should receive anticipatory guidance on the need for lifelong follow-up healthcare. And I really think starting those conversations in early survivorship is one way to really help facilitate the groundwork for a healthy long-term survivorship. The last standard I want to highlight is standard 11, which discusses the importance of school reentry support following cancer treatment. So, for patients and families, the transition off active pediatric cancer treatment is a milestone that's typically marked by mixed emotions, including excitement about the completion of treatment, as well as uncertainty about what the future is going to look like. Increased distress initially during this transition is certainly not uncommon. And we can think about this in the context of this being really the first time that patients and their families have stepped back and exited from the survival mode and are able to truly begin to process their cancer experience. So throughout the next couple of slides, I want to highlight some data and quotes from the 2022 survey of childhood cancer survivors through Children's Cancer Cause, as I think this really helps us to understand the lived experience of survivors from their direct report. So 41% of survivors endorsed challenges related to mental health, with one survivor stating, "It took me almost 3 years to get my life back." Another challenge that becomes more prominent during early survivorship is fear of recurrence or fear of development of a new cancer. And this can be particularly pronounced as patients transition from really very close medical surveillance, often being seen weekly or biweekly, to having a significantly longer period of time between appointments. 46% of survivors endorsed a fear of recurrence on the Children's Cancer Cause survey. And one survivor stated, "Every time I don't feel well, I worry that my cancer is back." Follow-up appointments for patients and families are often met with, again, a mix of emotions. So fear about what imaging or test results might show, while also feeling relief that someone is going to be making sure that they're okay and having eyes on them from a medical perspective. One study looked at how adolescents respond to this type of cancer, fear of cancer recurrence, and found that most adolescents sought reassurance from their parents regarding their fears of recurrence. But there was a cohort within the study of adolescents who described managing their fears of recurrence by turning to Dr. Google, which we all know is not a consistent and reliable source of information and certainly can breed even more anxiety and stress. I anticipate that this will soon be replaced by Dr. ChatGPT and other AI. And so I think it's really important for survivors and their families to have access to qualified medical professionals and information that they're able to turn to. 38% of survivors endorsed fears related to development of a second cancer, with one survivor reporting, "There's a fear that anything I do wrong regarding my health will lead to a new cancer," which is an enormous weight for a survivor to carry. I think there are some other challenges that we see in early survivorship, and many patients and families describe early survivorship as a time of decreased support. They have less communication with their healthcare team, who in some ways has become an extension of their family during treatment. Families also describe this as a significant loss and comment on the fact that those in their community that rallied behind them at diagnosis and during treatment don't always understand the need for continued support during survivorship. Okay, this is a conversation I have probably at least once a week with patients and families who are preparing to return home following cancer-directed therapy. And they tell me, "I just want to go back to normal." And we often have to have this conversation of normal looks different following cancer treatment. And it doesn't mean it's good or bad, but it is different in setting that expectation that rather than returning to exactly what life looked like pre-cancer diagnosis, this creation of a new normal and what integrating diagnosis and treatment looks like into their life following treatment completion. So research suggests multiple challenges that patients and families experience during this time. And I think one particularly salient issue in early survivorship is fatigue. So it's classified here in the Children's Cancer Cause Survey as cardiac problems. So it really does speak to challenges with fatigue, with 21% of survivors endorsing challenges in this domain, and one survivor stating, I feel like I need to take a nap after school. I have to distract myself, or um, I will. And if I do fall asleep, then I ruin my sleep schedule. Ongoing fatigue can make it really difficult to participate with peers and in activities in the same way they did pre-cancer, which can be really frustrating for kids and adolescents who really just want to go back to normal and feel like they've put their life on pause for a long time during treatment and are just ready to do the things that they enjoy. I think there's also often concern about potential perceptions from others regarding their fatigue. Does it make them look lazy or uninterested? Adolescents also comment about the uncertainty of how long will my fatigue last and how am I supposed to manage this? In a recent study, fatigue also impacted adolescents' return to school, as did perceived cognitive challenges and ongoing brain fog. So in the Children's Cancer Cause Survey, 32% of survivors endorse neurological late effects, with one survivor stating, I have lasting memory loss and executive functioning disorders. I find it hard to stay organized in my college classes. While accommodations are often recommended and necessary in setting patients up for success following completion of cancer-directed therapy, there can be some pushback regarding these accommodations, both from schools and from patients who want to be seen as normal and don't want any additional attention or what they might perceive as special treatment. And schools sometimes don't understand the lasting impact of cancer-directed therapy and expect that children and adolescents should be able to return to their pre-diagnosis functioning following completion of treatment. So we've talked a lot about fatigue and cognitive challenges, and I want to shift a little bit here and talk about the family dynamic. There is certainly frequently a shift in parental expectations from during treatment to early survivorship, and this is probably one of the conversations I have most often, where kids will say, oh yeah, before I got diagnosed, I was supposed to make my bed and take the garbage out and clear my plate from the table after supper. And parents often say, well, of course, now that we're done with treatment and you're going back home, like we're back home and those are your chores. You will make your bed, you will clear your plate, you will take out the trash. And kids often respond with like, that's hilarious to me. I haven't done this for 6 months now. I'm certainly not about to start doing that again. And so we really highlight open communication about this shift in expectations just to make sure that everyone's on the same page, because frustrations and tension can certainly develop between parents and kids if they have different perceptions of what's expected following treatment. I think another important point to touch on is siblings. And I think one thing that I really loved in looking at a lot of the literature in advance of this talk was seeing how often siblings are perceived by adolescents as supportive in early survivorship, with adolescents really voicing their appreciation for their sibling not treating them differently. However, there were challenges that were still acknowledged, especially with kids as they began to have to share parental attention, and sibling frustration with any remaining accommodations for the survivor that felt like special treatment. Okay. There we go. So peer relationships are of immeasurable importance during childhood and adolescence, and I know that's not new for this group. Upon returning to spending time with friends in person during early survivorship, a portion of survivors describe challenges related to feeling comfortable with their physical appearance. So, change in physical appearance from weight gain or loss, surgical scarring, and hair loss can be seen as visible reminders of cancer that children and adolescents may want to forget. So 17% of survivors polled during the Children's Cancer Cause survey endorsed concerns related to body image, with one survivor stating, "My body has changed greatly, and it makes me anxious and self-conscious daily." Adolescents also commented on the inability for their friends and peers to truly understand their cancer experience. So many shared that they felt hesitant to talk about it with their friends as they really just wanted to be seen as normal. They talk about they've given so much of their life to cancer and had so many conversations that revolved around cancer that they are just really ready to not talk about cancer for a little bit. Further, it's not uncommon for priorities to change during treatment. So when faced with their own mortality, the concerns their friends are discussing about dating or grades in school can seem really trivial. And this can create a chasm or disconnect between cancer survivors and their peers. Okay. Is someone else monitoring the waiting room? I'm getting just some notifications that people are waiting to join, so just want to make sure. I'm trying to keep an eye and let people in. But if someone else is able to help with that, I
Yeah.
would super
Yeah, don't
appreciate.
worry. I'm doing
Okay,
that. Don't
awesome.
worry.
Thanks, Alyssa. All right. So this is also a phrase I hear a lot, especially when I see families after they've gone home following treatment and are coming back. They'll say, "This isn't what I expected." And research really backs that up and suggests that some adolescents and parents don't think a lot about how life post-treatment might look different, and many expect to really pick up right where they left off. Adolescents experienced more challenges than they expected, especially from physical symptoms associated with treatment, like fatigue, as I mentioned, but also ongoing pain and brain fog. And adolescents noted changes in their physical abilities and stamina, particularly in comparison to their peers. And the challenges adolescents experience are also not what many in their social circle expected. So many, I think, perceive it as a light switch where cancer's over and everything's back to normal. And that's a hard reality, I think, for survivors and also for individuals in their environment following cancer-directed therapies completion. So I want to just highlight this chart because I think developmental considerations in survivorship are so important. Um, so this chart was published by Darlington and colleagues. And when we consider childhood cancer survivorship, I don't think we do a really great job thinking about the differential impact of diagnosis and treatment for those diagnosed as children and those diagnosed as adolescents or young adults. And this chart describes the unique developmental differences between childhood and adolescent cancer survivors and highlights the importance of gaining clarity regarding developmental differences in order to identify unique needs and tailor psychosocial interventions. So this graphic also comes from the 2022 Survey of Childhood Cancer Survivors by the Children's Cancer Cause and presents quotes about childhood cancer survivors' experience following curative therapy. I found many of these quotes to be enlightening, sobering, and also troubling. So one survivor shared, "The journey never truly ends. For me, I really don't experience the emotional and mental aspect until my treatment was over and I entered survivorship." Another stated, "Sure, I'm not in active treatment anymore, but I'm still dealing with healing physically and mentally, as well as seeing many specialists and doing many tests. Our free time is consumed quite often with medical necessities, and it can be exhausting." And finally, one survivor shared, "Cured looks different for cancer survivors. The concept of cured for cancer survivors is only equal to not dead or dying from cancer." Whew. So we just saw some representative quotes from childhood cancer survivors, and I want to talk about some of the data related to psychosocial functioning in early survivorship specifically. So this study enrolled children ages 4 to 16 with a diagnosis of ALL who had completed treatment within the last 3 months. There was a second group of age and sex-matched healthy controls that was also recruited. And all measures completed were self-report and were administered at 3 time points, so 3, 15, and 27 months post-study enrollment. There are no significant differences at 3 months post-study enrollment, but significant differences in school functioning were found at 15 months, with those treated for ALL having lower school functioning. And at 27 months post-enrollment, significant differences were found for social functioning, school functioning, and overall health-related quality of life, with those treated for ALL having lower functioning across these domains. So in another study, children ages 5 to 18 at diagnosis and their parents were recruited, and Winning and colleagues reported on academic and social functioning, as well as anxiety and depressive symptoms at diagnosis, and then again 3 years later. So participants were split into 2 groups, those who received CNS-directed therapy and those who didn't. At diagnosis, there were minimal differences by diagnosis or treatment group. But at 3 years, mothers and fathers reported poorer social competence for those who received CNS-directed treatment, and fathers reported poor school competence at 3 years for the CNS-directed treatment group. And then all children demonstrated higher anxiety and depressive symptoms over time. In a recent systematic review, Conway Keller and colleagues identified positive and negative predictors of health-related quality of life in early survivorship, with positive predictors including positive family functioning, identified coping strategies, and post-traumatic growth in adolescence, while negative predictors included low social support, negative experiences during treatment, longer treatment duration for adolescents, and parental post-traumatic stress at diagnosis on parental health-related quality of life during early survivorship. So while the return to primary care is certainly the natural next step for routine medical care following completion of cancer treatment, there are a number of barriers that are present. So occasionally there's misdiagnosis prior to the initial cancer diagnosis that leaves families with a sense of mistrust of their pediatrician and apprehension about returning to them after treatment completion. Pediatricians are also typically not involved during cancer treatment and as such are not informed along the way of potential survivorship care needs. Further, pediatricians often don't feel equipped to manage the complex medical needs of cancer survivors. Recommendations for facilitating the return to primary care discussed in this study included providing targeted information to pediatricians who will be caring for cancer survivors through treatment summaries and survivorship care plans. So there's a plethora of literature that highlights the importance of health behaviors in survivorship, and I certainly won't do this aspect of survivorship justice with this one slide, but I do want to highlight a study that looked at health behaviors specifically in early survivorship. So this study by Fisher and colleagues looked at health behaviors in children and adolescents at 3 and 5 years post-diagnosis, with report from both survivors and their mothers. In this study, most survivors were meeting expectations related to high-intensity exercise, fast food restriction, and sleep, but were below expectations for engagement in low-intensity exercise, fruit and vegetable intake, and dairy consumption. They found health behaviors were largely stable over time with only a significant decrease in sleep duration by mother report. I want to highlight too, this is just the results from one study and is certainly not a representation of health behaviors and survivorship broadly, but I did think important to mention. So we've talked a lot at this point, or I guess I've talked a lot at this point about psychosocial functioning and early survivorship, but it's clear that not all needs are being met, or at least I hope that's clear to you now. Research highlights the importance of psychosocial support throughout the cancer care trajectory and indicates significant unmet psychosocial needs at the transition off active treatment. Many families report feeling uninformed about what to expect post-treatment and expressed a desire to better understand potential late effects. So, routine screening in early survivorship is integral to identifying these needs, providing targeted support, and setting the stage for a healthy survivorship. And although psychosocial involvement in survivorship programming is well established, there's been less emphasis on programmatic efforts during the period between treatment completion and entrance into long-term survivorship. So routine and systematic screening also allows for the facilitation of equitable access to this screening and associated interventions provided during these appointments. And screening is also recommended based on research and the psychosocial standards of care. So we asked families at St. Jude what they would have liked in early survivorship. And so here are some quotes we heard from families. I'm going to pause here and let you guys look at these quickly. So now I want to circle back to this slide that represents the gap in systematic psychosocial support during early survivorship, and now talk about a model we're using at St. Jude to meet that need. So here at St. Jude, the Transition Oncology Program, or TOP, as I'll refer to it, was established to provide systematic support to patients during early survivorship. So TOP launched in December of 2018 and expanded its reach to include transplant and cellular therapy patients in 2021. The program is led by Dr. Emily Brown and includes an interdisciplinary team comprised of nurse practitioners, social workers, psychologists, a nurse transition coordinator, a patient navigator, and school advocacy coordinators. Prior to TOP at St. Jude, there really was a lack of prospective screening for psychosocial and cognitive concerns, and many patients only receiving services after problems were identified. Additionally, there was variable coordination with local primary care and specialists, and I'm excited to share that currently TOP serves over 1,700 patients and families during early survivorship. So to talk a little bit about the scope of TOP, which includes the following: to provide systematic screening and support to patients from near treatment completion until their entrance into long-term survivorship, to acknowledge this significant transition and to provide anticipatory guidance and psychoeducation related to the transition off treatment and into early survivorship, to provide education and resources related to transition and early survivorship, to screen for potential psychosocial, cognitive, and physical risk factors that may impede successful transition, and to assist patients and families with initiation of local healthcare providers, including local mental health providers. So as I mentioned previously, TOP is an interdisciplinary team. Our nurse practitioners introduce TOP to patients and families, and one of the unique roles that they have that I think is so incredibly pivotal is the development, update, and provision of treatment summaries to our patients and families. So this allows for patients and families to have something in hand to provide to their pediatrician, however, also allows them to have a comprehensive snapshot of their treatment for themselves. Our nurse practitioners also serve as a liaison between the primary oncology team, local primary care, and subspecialists, and provide education about late effects, health behaviors, and health literacy. Our social workers conduct vocational, educational, and mental and behavioral health assessments, ask about insurance status, and assess access to local medical care, as well as screen for any concerns related to medical decision-making, such as need for conservatorship or a healthcare agent. They also provide supportive counseling, anticipatory guidance, psychoeducation, and local referrals. Our school advocacy coordinators educate patients and families about cognitive late effects. They assist school personnel in understanding the impact of treatment. They provide recommendations for IEPs and 504 planning, and they follow up regarding results of brief cognitive assessments that we conduct. So our transition coordinator and patient navigator help families identify local providers. They educate families on obtaining services in their home community. They assist families with navigating insurance benefits for care, help coordinate with Head Start, early intervention, and school. And our patient navigator is our lifeline and our touch point in between family return visits to St. Jude. So I'm going to talk more in depth about psychology's role in a couple of slides, but acknowledging that we are also part of the team. So this is our typical timeline for engaging with patients and families in early survivorship. However, I want to make sure to point out that it does look different for those diagnosed with ALL, who psychology meets at reinduction 2 as families are preparing to enter into maintenance therapy and really begin to resume much of their daily activities, such as parental return to work, child and adolescent return to school, time with friends. I'll say our timeline also looks a little bit different for our transplant and cellular therapy patients, as their treatment timeline is less structured and often dependent on their post-transplant course. I always love a good case example, and so want to share one that highlights the role of psychology within TOP. So Molly is currently a 16-year-old American Indian female diagnosed with AML. She resides with her family in the Midwest and was treated here for AML and is status post bone marrow transplant. Her treatment course was complicated by acute skin and GI GVHD, as well as avascular necrosis. So Molly was diagnosed in February of 2020 at the age of 10. I saw her shortly afterwards for a psychology consult due to concerns related to adjustment and coping. I followed her throughout treatment at St. Jude to assist with coping and anxiety symptoms. And Molly was referred to TOP in March of 2021. So before talking more about how psychology supported Molly during this transition, I want to spend some time talking about psychology's role more globally within TOP. So psychologists evaluate for psychosocial and family functioning factors which may negatively impact transition, provide broad anticipatory guidance and psychoeducation, including established patient education related to common challenges patients and families sometimes experience during transition and early survivorship. We also seek to provide tailored and individualized recommendations to patients and families based on those identified concerns. We encourage the initiation of local mental health services when indicated and offer assistance when needed. We assess for potential cognitive, academic, and vocational risk factors and work with our school advocacy coordinators to provide recommendations to bolster success within the academic or vocational setting. Okay, so now back to Molly. I saw Molly for her TOP psychology consult in April of 2021, and concerns that came up during that consult included decreased social engagement, which is due in part to the ongoing COVID-19 pandemic. Molly was treated almost exclusively during COVID, as well as Molly's recent bone marrow transplant and immunocompromised status. The family reported that Molly had been able to keep in contact with her friends virtually and have been very open with them about her cancer experience. The family denied any significant concerns related to transition and were very receptive to guidance and education I was able to provide. So during the TOP consult, the following domains are assessed. We talk a lot about emotional processing and coping skills related to transition, including how the patient and family are feeling about the upcoming transition off treatment, level of distress they're experiencing, and identified coping skills that were helpful during treatment that they can then leverage to support positive adjustment and coping in the context of transition. We ask about patient emotional and behavioral functioning, including mood, behavioral concerns, sleep, adherence, ongoing difficulties with pain. family efficacy around care for the patient, including roles and responsibilities family members will have upon returning home, expectations for the patient, including chores, family's understanding of any ongoing medical care needs and management of that care. We spend a lot of time discussing social adjustment and social functioning, including how patients are feeling about returning to school, spending time with friends, and sharing their cancer experience. We assess for family knowledge of school supports and encourage engagement with our top school advocacy coordinators. And recognizing that our adolescent and young adult patients have some unique needs at transition, we address transitions to adult care and managing healthcare independently, as well as concerns about cancer recurrence, body image concerns related to physical changes secondary to treatment, and fertility and sexual health. So in addition to the tailored recommendations we provide based on concerns that arise during the consult, we provide all families with patient education materials to support the transition off treatment and into early survivorship, including ways caregivers can support siblings. You'll see the QR code here. I'll pause for just a second in case anyone wants to take a quick scan for this resource. I should mention too, this one and other resources I'll share are available at together.stjude.org. We also provide developmentally tailored patient education on friendships after cancer. And again, both of these, along with many others, are available on the Together website. So Molly was seen for a top brief cognitive assessment in May of 2021 when she was 12. Molly's performance on the assessment was consistent with difficulties in multiple domains. The family had made the decision for Molly to repeat the 6th grade and were involved with the school program and our school advocacy coordinators to establish accommodation to support Molly's success within the school setting. And given the concerns noted on that assessment, Molly was scheduled to complete a comprehensive neuropsych evaluation. So a combination of performance-based tests and behavior ratings is used during this brief cognitive assessment to briefly assess development, neurocognitive domains, academic skills, and emotional and behavioral functioning. I think it's important to note that our involvement with patients and families doesn't always end after these 2 visits, so after our consult and assessment visits. So I saw Molly again in March of 22 when she was 12 at the request of her medical team due to difficulties with pain and coping following her most recent knee surgery to address avascular necrosis. And I was able to provide support to Molly while she was hospitalized, assisting with non-pharm pain management strategies to promote improved pain coping. And Molly was discharged and doing well at that time. However, Molly's mom reached out to me a couple of months later after Molly had turned 13 because Molly was experiencing a significant exacerbation of anxiety symptoms. I provided the family with patient education on initiating local mental health services. And when I saw them again, when they were back in June of 22, they had successfully established local mental health care for Molly, and she was benefiting from regular psychotherapeutic intervention. After being contacted by Molly's mom, I saw her again in July of 2024 when she was 15 due to recent onset of seizure-like activity. So she had 9 days of consistent events followed by resolution of symptoms. She had a full workup done at an outside hospital that was negative and no medical cause was identified for her symptoms. So I was able to provide psychoeducation on functional neurologic symptoms and encouraged ongoing follow-up with Molly's local mental health professional. We were able to talk about some of the recent stressors and things that have been going on in Molly's life. And Molly shared that she had actually, prior to this, had just met her donor from her bone marrow transplant. So we surveyed providers from primary clinics at St. Jude following the implementation of TOP, and we received generally very positive feedback. And so I want to provide just a couple of representative quotes from that survey for you all to look at. In addition to qualitative data, we wanted to examine if a transition-focused psychology visit increased caregiver report of feeling informed and prepared as they entered into early survivorship. So we conducted a study at St. Jude with 57 caregivers to really understand their experience of the transition off therapy. And we found that caregivers perceived transitioning off therapy as stressful for their family, which is consistent with what we find in the literature. Though they experience decreased familial distress when they feel informed or prepared to manage transition-related challenges in early survivorship. I think this is particularly important because it suggests a possible indirect effect of transition-focused psychology visits on the relationship between feeling informed and prepared and the experience of distress. So now to bring it all together, so just some broad conclusions. There are significant and unique psychosocial challenges at the transition off therapy and during the early survivorship period. Routine screening at this time allows for identification of needs and the provision of psychosocial supports, as well as universal anticipatory guidance and psychoeducation. And families and providers at St. Jude have been really receptive to our model for providing the screening and care in early survivorship. So I want to thank you all for your attention and open it up for any questions.
Thank you so much, Anna. And I think we have a question here from Lisa. Do you want to say your question yourself?
Now, let's give a floor to participants. We had a question here
Yes,
in
I
the
thought she
chat.
might want to talk by herself, but maybe she can't.
Yes, I'm going to stop sharing just so I can see everyone and we can have a more interactive discussion.
Say the question, Alisa. Lisa, if you want.
Yeah, I will read the question of Lisa. Are these educative efforts applied to everyone or based on screening outcomes?
That's a great question. So everyone, if you're talking about the cognitive screening, everyone receives the cognitive screening. And then, yes, if there are concerns identified, then our school team will work to put in place accommodations with their local school. However, there are standard things that are provided for all patients and families. So all of our patients and families receive school advocacy support, regardless of results of that testing. And our school advocacy coordinators work really hard to make sure that they're providing information for teachers that go over specific risk factors and ways that they can support the child during that reentry into the school system.
Thank you very much. I was just looking to turn on my microphone. Thank you.
Yeah, no worries.
Yeah, and Patricia is asking whether the recording will be shared. Yes, Patricia, later we'll share the recording of the webinar.
I do have a question as well, if no one else is
Absolutely.
asking. I wonder, I mean, a lot of us work in clinics that are not able to have this great group of top, like the top program. Well, what do you think is the least we can do for the early survivorship patient?
Yeah, I think that's a question that comes up frequently. And one of the things that I think is important is partnering as a psychosocial team with the medical care team. And so even if you're able to have a handout or point them to some of the resources I shared on the Together website, I think that that's something that can be really helpful, is just having some of this education and guidance that exists on the web. And I think also if there is room to screen for maybe a couple of things, like whether that's anxiety or depression, if we think about just kind of the long-term follow-up guidelines, I do think finding ways to prioritize those things that are going to be most impactful and most suggestive of potential ongoing challenges that might need support.
Thank you.
Mm-hmm.
Have any other question? Maybe someone want to talk out loud, not write it down.
Yeah, we have a question. Lakshmi is asking, how frequently do you screen evaluate in survivorship? Is it routine or need-based?
That's a great question. So we have an incredible social work team that is embedded within our survivorship, our long-term survivorship clinic. And so they are screening yearly. In early survivorship, that looks a little bit different and has been more needs-based during that period between treatment completion and long-term survivorship. So psychology is seeing them at that transition off treatment. And social work is also following up 3 months following their treatment completion and then remaining available to check in as needs arise.
Thank you.
Thank you.
Absolutely. Thank you guys so much for having me.
It was wonderful. It was great talk. And I think it's a lot going on in many of our countries regarding transition and early survivorship. So this was very good. Thank you.
Awesome. Thank you all.
Yeah, this was very useful webinar for all of us.
I'm so glad.
Yeah.
Wonderful.
We
Well,
have
happy
comments
Survivorship
about
Month.
So, and I would like to add, just to
Yeah.
add
Yeah,
about
of course,
survivorship group, because I didn't do that in the beginning, but I would just say that this is a new formed group, and our goal is to make global awareness of survivorship of childhood cancer, of course, for the patients. So we are trying to provide access to useful information and for around the world and in all global settings. So we are starting up, and we've started out to have webinars, and we're going to be seen at SIOP, of course, in Amsterdam. But if you're interested, you can look for SIOP Survivorship Network, and you can join and you can get information on the web page. So I invite you all. Oh, here we have a new question.
Yeah. Mm-hmm.
Wonderful.
What's one aspect of early survivorship that often gets overlooked but makes a significant difference in long-term outcomes for pediatric patients?
Ooh, this is
That was the difficult question.
Yeah. Okay, here we go. I'm ready. Gosh, it's hard to pinpoint one specific aspect that I think is more or less important. I would say thinking about health behaviors. So thinking about diet, exercise, sleep, we certainly know has a big impact on mental health, but also physical functioning. I think one of the things that I find that I'm highlighting most is talking about with kids and families how to share their cancer experience, how to respond to the onslaught of questions they receive when they go back to school. I think that's something that a lot of kids and adolescents don't feel particularly prepared for, and really benefit from that support and reintegrating with their peer network. We know that peer relationships are so critical for overall psychosocial functioning. So I think that's maybe one thing that I would highlight.
Thank you. It was a thumb up here from me. Alicia, would you like to add something?
If we don't have another questions, I guess we can, if you don't have other things to add, Maria, we can complete this awesome and very useful webinar. Thank you for all the participants, for the questions, of course to Anna, and of course to our survivorship network for this great collaboration.
Thank you all so much. Take care.
Thank you. See you soon.